I've put this lecture in the context of the Heart Talk, which is looking at financial incentives on quality of care of maternal and newborn services. And as a bit of background, I thought before I actually go straight into the program, I'd actually just bring us into the context of the whole thing. And that is that now we know that much of maternal mortality and morbidity actually happens in the peripartum period. That's just around the time of birth and immediately after. And therefore, there's been a lot of literature that encourages governments to focus on this particular period, because if you can actually work with mothers at that point in time and ensure a safe delivery, then you're actually going to be able to bring down your maternal mortality and morbidity. So a number of governments have actually tried to follow this recommendation, and they've used different ways to try and do this, and one of the ways has been to promote institutional delivery. There's been a massive push in many parts of South Asia to actually move mothers from home deliveries into the hospitals. And the rationale for this is that if you deliver in a facility, then you have access to emergency obstetric care, which can be life-saving. So emergency obstetric care there are a number of functions that actually go into emergency obstetric care, which I'll go into later, but emergency obstetric care can only work if it is of a decent quality. If the quality of emergency obstetric care is poor, then it's pretty much as good as not having the emergency obstetric care at all in the first place. So the problem's actually been that in many low middle income settings, the state of the public health sector is often not optimal for a number of reasons. There are structural problems, there are problems of it being underfunded, there are problems of human resources, there are a lot of problems. So how then do governments in low middle income settings actually manage to provide good quality emergency obstetric care? It is a really tricky question, because if you don't have good quality obstetric care, it's as good as not having any care at all. So very quickly, this is theory. What is really emergency obstetric care, and what would make a facility capable of providing emergency obstetric care? So we've sort of split this into 6 basic indicators and 2 extra special indicators. And the basic indicators are the ability to provide antibiotics, anticonvulsants, and oxytocics, which are life-saving. The ability to remove the placenta if it gets stuck. The ability to remove retained products of conception, and to assist vaginal delivery if it requires assistance. And if a facility is able to do these 6 functions, then we say it's capable of basic emergency obstetric care. And then there are 2 more, which are really the ability to perform a cesarean section and blood transfusion, both of which are extremely life-saving interventions in an emergency. Now, what this would mean is that you need to have staff in place in an environment that can support them. And the staff need to be able to be skilled enough to identify these complications early, because many of these complications are rather catastrophic when they occur. They occur suddenly and progress rapidly. So you need to have staff in place who can actually identify these complications, and then once they've identified the complications, they should know exactly what to do and have access to the medicines and drugs and equipment that they need to actually even first line manage these complications before they call on a specialist if available, or refer the patient out. These functions need to actually be 24/7 services, because an emergency can crop up anytime. It really requires staffing. Staff are very, very key in this whole management of EmOC. You can't manage it if you don't have competent, skilled, qualified staff. And then referral capacity, because at lower level facilities, which are just basic facilities, they need to be able to first line manage and then refer the patient out as quickly as possible, because this is a developing emergency which could cost lives. So back to the problem now of good quality EmOC. Now the challenge is really that good quality emergency obstetric care in underfunded, understaffed public facilities is really a challenge. And just pushing mothers into a facility and saying, yes, this is a facility birth, doesn't really save lives. It might help with statistics, but the quality of EmOC is really, really critical with regard to saving lives. So how does the state in a low-income setting then come up with the means of providing good quality EmOC to its women? And that's the question which actually brings in the private sector, and how can we rope in the private sector keeping in mind all the incentives, etc., that work differently in the public and the private sector. With that, I'm going to get into the case study, what's called the Chiranjeevi program in India. So Chiranjeevi means long life. Its translates into long life. And it's a program that was largely designed to provide access to vulnerable women. And vulnerable women are women living below poverty line or tribal women in one state in India, in Gujarat, and to ensure that these vulnerable women who actually bear the brunt of maternal mortality and morbidity have access to good quality emergency obstetric care when they're giving birth. So it's called the Public Private Chiranjeevi Yojana to support institutional delivery in Gujarat in India. So now let me come back to the question that I left off with. So how does the state in a low income setting come up with the means to provide good quality emergency obstetric care to its women when we know that the public sector, the public health sector has its limitations with providing emergency obstetric care? So the first thing is to look at where is EmOC currently available? What are the resources that there are, and how do we match potential women who require this care with these resources? Now, this is a case study from India, which makes it a bit special in that India has one of the most privatized healthcare systems in the world. And 75% of all health expenditure in that country is actually made out of pocket at the point of care, and not from formal insurance, because formal insurance is very, very small. About 2 to 3% of people actually have formal insurance by virtue of formal employment, etc. So the private sector is huge, it's extremely heterogeneous, but there is a lot of qualified skilled care available in that private sector. So the majority of qualified obstetrician gynecologists actually practice in the private sector in India. They often have their own privately owned and run practices, which often include small inpatient facilities. They're not fancy large public hospitals, there are those, but that's not what we're focusing on. These are smaller facilities, maybe 10 to 20 beds with a full operating theatre, access to an anesthetist, etc. Now the problem with these is that even though there are so many of these nursing homes, they're called nursing homes or hospitals available, access for poor women is precluded because of financial access barriers. Since out-of-pocket payment is the modality of payment, the poorest of women who really need this care aren't able to access it, and then therefore either deliver at home or deliver in dysfunctional facilities or facilities where they have to pay out of pocket, and that drives them into poverty. So this is the backdrop of the health system in which this program was nested. There's been a lot of debate on whether this is really, are we going towards privatizing the health system, or are we weakening the public health system by moving patients into the private health system, etc. But really, if you were to stand back and look at it, the role of the state is really to ensure that its women, its most vulnerable women, have access to the care that they require. It is to steer the entire health sector, the public as well as the private health sector, to make sure that this care is available. And the question is really, how do we constructively harness that big, huge private sector resource that we have to be able to deliver public health outcomes? It's not really privatization. It requires a strong element of oversight and knowing what you want and how you get it in a way that is not to the detriment of the patient. So it is, if you look at this saying by Deng Xiaoping, it doesn't matter if the cat is black or white as long as it catches the mice. So that's the whole thing. So the Chiranjeevi Yojana was started in Gujarat as a state-led public-private partnership in 2007. I'm coming a bit to the rationale of why it was started a little later, but in short, suffice to say now that it was because there was a recognition of the inability of the public health sector to actually provide good quality emergency obstetric care. And that it was a partnership with private qualified obstetricians who practice in the state. It was done quite sensibly because the risk with actually involving private providers in intrapartum care is that you can actually have a whole lot of unnecessary cesarean sections in there. And so the way they worked it out was that they actually had an embedded disincentive for cesarean sections, and they actually had this kind of package. They paid providers for every 100 deliveries they did of women who were either below poverty line or tribal, and they paid them a block amount. It didn't matter how many were cesarean sections or how many were normal vaginal deliveries. You just got X amount for 100 deliveries, and the package was in blocks of 100. So far, the program has actually been quite large. It's done 1 million deliveries of below poverty line and tribal women since its inception in 2007. And for those of you who don't have a sense of the Indian context, so the government of India issues below poverty line cards and tribal cards to people belonging to these groups. So they have a census every 5 years where they assess poverty status, and if you qualify, then you get a card which says you belong to a BPL household. And similarly, if you are of tribal origin, then you have a card which says you're tribal. This is the state of India in which it runs. This is Gujarat on India's western flank. It's one state, it's got a population about the same as the UK. So it's about 60 million people. It currently has a maternal mortality ratio of 148. That's 148 deaths per 100,000 live births, and an infant mortality rate of 41. Questions that I'll quickly go through with this presentation is the rationale of the program. What's been its contribution to institutional delivery so far? What's been the uptake among the vulnerable group of the population? And what's been the quality of care in the program? I'm going to skim through the first three because the focus of this talk is really on the quality of care issues. But if you really want to look at more, then there's the website which you can take a look at later on. So, like I said, the rationale for the Chiranjeevi program was the inadequate provision of emergency obstetric care in the public sector, and importantly, an acknowledgement and a recognition of this inadequate provision of care. At the time that the program started, you could count the number of obstetricians in the public sector on your fingers, and the number ran into hundreds in the private sector. So it was really imbalanced. And then in preparing for this lecture, I actually looked at the National Health Mission reports on health infrastructure. And at secondary care level, they had 318 vacancies for obstetricians and gynecologists, 9 of which were filled. So it means that there was a vacancy of 309 positions of obstetrician gynecologists in the public sector. But what's been good is that there's been a formal acknowledgement that this is a problem, and if you don't have this, you can't really provide good quality EmOC. So the strong private provision of EmOC with qualified obstetricians, when the Chiranjeevi started, there were 2,000 obstetricians in the state of Gujarat, 2,000 qualified with a postgraduate specialist degree. And because there were so many of these, they were not just concentrated in the capital cities. They are, but then they also moved down to the block level. So you get qualified obstetric care down to the small towns in the state, which I think is special and makes this program a possibility in the state. So initially, when the program started, when the government said, okay, we want to partner with you, we want to do this, we want to start this scheme, 860 of the 2,000 private obstetricians in the state actually signed up to be part of this program. So it was like nearly half the obstetricians in the state were Chiranjeevi providers. So if you were to just look, this graph actually looks at the way facility birth has changed over the last decade. And if you look at the thick green line that's going upwards, that's the line that tells you the change in total facility-based births over the last 10 years. And you can see that it started out at 40% in 2001 and then rose to close to 90% at the close of the decade. Now, much of this rise in facility births was driven by a massive increase of births in the private healthcare sector. And if you look at, that's the dashed green line, those rose from 17% in 2001 to close to 50% in 2010. That's not counting the births under the CY program. If you include the births under the CY program, then you see that the CY contributes to about 15% of all births, which means total private sector institutional delivery goes up to 60%. So 60% of that 90% is actually happening in the private sector. The public sector, in the meanwhile, which is the dashed and dotted brown line, has actually stayed more or less constant with a small rise after 2008. And then over the years, it's been more or less steady. What's interesting is that there hasn't been a huge increase in uptake. It's been more or less steady at about 15% of all births right up until now. Now, if you were to look, this is actually looking at the coverage of the program, that is, what proportion of those who were eligible for the program actually took it up. And if you look at the dark black line on the top, on average about 1/3. 1/3 of all eligible births happened under the program. And this means that the remaining 2/3 are going somewhere else, either to public healthcare facilities or delivering at home, we don't know. And the grey line is less important. It tells us that about 15% of all institutional births happened under the program. Okay, this is just a slide we can quickly look at. These are 3 districts where the Maternal project runs, where we actually did GIS work to kind of map out where the CY facilities are and what increase in coverage they actually offer. It's a bit difficult to see, but the blue stars are the stars that are the facilities that are actually running the program. The blue stars. So the red are public facilities that are capable of providing CMOC care. And usually you'll see that's just 1 in every district. The green stars are private obstetricians capable of providing specialist care but not participating in the CY program currently. This map is dynamic, so this is a snapshot at one point in time. And then the blue stars are the stars of the facilities that actually are currently participating in the CY program. And in the middle district and the last district, you can see that they are actually in blocks or areas that actually don't have any other facilities. So it's, in a way, they also increase access. So I'm not going to focus much on access because access is not the focus of this talk, but they do contribute to some increase in access. Now, coming to what this lecture is to focus on, which is the quality of care measures for intrapartum care. Now, quality of care is an extremely complex concept. There are so many domains, there's so many aspects, there's so many perspectives from which you can come to it. So I tried to sort of put it into this health systems framework and talk of it from that point of view. So if you have a program that's targeted towards safe maternity and intrapartum care, you'd have inputs, you'd have to put in money, you'd have to put in human resources, train people, have managerial systems to manage flow of information, etc. for the program as inputs. Then you'd have outputs, and outputs would actually be the level of emergency obstetric care, the skilled staff that are available in the facilities, the drugs, the equipment, etc., what transport, referral transport is available. And then outcomes will then give you outcomes, which is how many skilled birth attendants there are, what are the critical service interventions that have been done in these facilities, and then that's going to result in an impact, which will be either a drop in maternal deaths, perinatal deaths, a decrease in maternal morbidity, etc. So if you were to now superimpose quality of care onto this framework, you would see that if you could measure the outputs and the outcomes, which are the 2 middle boxes, they would provide you some indication of the quality of care that's provided in the program. So if you could look, for example, at the EmOC services, what is the levels of staffing, the availability of drugs, equipment, look at emergency transport, etc. You could. You could also have some measure of quality of care from the impact, but it's really tricky to do that because maternal deaths are so few, and then there are so many implications, so many pathways that lead to a maternal death. It's hard to tease out and say, oh no, it was a program that did this or didn't do this. So that's a bit tricky. So it's easier to kind of focus on the middle 2 boxes. So the quality of emergency obstetric care under this Chiranjeevi program. So the first thing is that it had a number of inbuilt provisions to actually ensure quality of care in the first place. And the first thing is the criteria of obstetricians, the criteria that they set for obstetricians who could participate in this program. So one is that the facility had to have at least 10 beds. It had to have a full-time obstetrician and gynecologist in that facility. It had to have an operating theatre where cesarean sections could be performed, and it had to have access to an anesthetist. And this was to ensure access to complicated emergency obstetric care because this is what's life-saving. So that's kind of a structural measure of quality that there was. Now this is a picture of a facility that is actually participating in the Chiranjeevi program. And the board on the left, the orange board says Chiranjeevi in the local language, and on the title is the delivery and gynecological treatment facility. So they aren't like huge, big, fancy, sprawling facilities. They're small facilities, but then they're available and they can do what it takes to save a mother's life. The next thing that we could look at from my framework on the quality of care issue is the level of emergency obstetric care that these facilities are able to perform. And I've divided this into 3 columns, if you understand the columns first. So the first column is the facilities that participate in the CY program. The second column is private facilities not participating in the CY program. And the third column is government facilities. And again, these numbers can vary. This is a snapshot that we did in 2012. Look at the last row now, the proportion of facilities that actually offer cesarean section and blood transfusion in that facility. And if you look at the CY facilities, 78% of those participating are able to offer cesarean section and blood transfusion. If you look at the remaining private facilities, the number is slightly lower, it's about 70%. And if you look at government facilities, it's extremely low at 14%. Just 5 of the 36 facilities are able to do this. You can see that there is definitely an increased access to cesarean section and blood transfusion in the program. And it's being paid for by the state. So the issue would be that if the women decided to move to the non-CY accredited private facilities, then they would end up paying out of pocket. So that's the level of emergency obstetric care. Then we can look at human resources, and the Maternal project actually looked at a whole host of human resources, but I kind of just tried to look at human resources that are really key, so obstetricians, pediatricians, and anesthetists. If you look at obstetricians in the public sector, 17% of public sector facilities had obstetricians. 100% of the CY facilities had obstetricians, and the private non-CY just 93%. So the private CY and the private non-CY are kind of similar. Because there are so many more public facilities, sometimes the public facilities can look worse because many of them are just little clinics that don't really do much delivery. So what we did is we actually excluded those. So this is really only facilities that do more than 10 deliveries a month, which means that they are actually high load facilities doing a reasonable number of births. So the 17% is discounting all the sub-health centers and little clinics, etc., etc. Then pediatricians, the proportion of pediatricians in the public sector 2%, CY 17%, and non-CY private 10%. Anesthetists again 4%, 31%, and 35%. So you can see there is a definite rise in skilled care that women will have access to if they were going into the program. Now, skilled birth attendants, this is very interesting and is actually a whole other topic in itself. So often the thing is, we're conditioned to think that qualified care equals skilled care, which is not necessarily the case, because often qualified care is not really skilled care. But what we saw, which is interesting in the Chiranjeevi program, is that they have skilled birth attendants who actually do their deliveries and manage straightforward, simple cases, who are trained by the private obstetricians themselves. They have myriad backgrounds. They can be pharmacists, they can be compounders, they can be men, they can be women, they can be anyone. But then they're trained and really under the eye of the gynecologist concerned. And so that in some way ensures accountability and ensures that the woman is treated well, as opposed to having a bunch of anonymous qualified staff who are not really skilled. So it's an issue that needs exploring, and one of my colleagues is working on this, but it is something new that I hadn't come across before. So these skilled birth attendants are not necessarily formally qualified, but they're trained intensely at the facility. And we actually did have some kind of vignettes with them, and they're actually able to recognize complications and know what to do immediately and when to call the gynecologist, cross-match type, blood, etc., etc. So they do have a level of competence. So that's the human resource issue. Now, talking about human resources is that, like I said, a strong qualified obstetric care private sector is the basis for this. It's going to be very, very difficult to run a program like this in the absence of a sector like that. But what's been interesting is that there's been progressive attrition of the gynecologists participating in this program. So it was 865 in 2007 when they started, and I think the 662 figure is around 2010, 2011, and I'm not sure what the figure is now. There's been progressive attrition of private healthcare obstetricians. And there are a number of reasons for this, which has been explored in some qualitative work that's been done by a colleague of mine. One of them is that it has been difficult with interfacing with the state for a number of reasons, and that payments get delayed, and that there are a lot of questions asked, and there's this basic mistrust that a lot has been written on between the public and the private healthcare sectors. That's been one. The second reason has been that they've often not found it remunerative enough. And the states addressed that recently because they've made steep hikes in what they pay the private obstetricians now. And the third reason is there's been the odd obstetrician who had one really bad case which required to be on a ventilator or had a massive anaphylaxis, and that kind of eats into more than all that she's paid for the other 99 births. So there are a lot of stories about why. It's interesting to look at why the private sector didn't really continue this interaction. The attrition tends to happen in the large cities more than in the smaller towns, and I think that's because there's so much competition between providers there, that because they will not pay you for CY until you've done 100 deliveries. So I think when there's a lot of competition, then providers struggle to meet that 100 number. And so if we look at now the level of supplies and equipment, so if you look at facilities that have access to a laboratory, to blood banks, and I've just written down certain key things that you'd need. So 25% of public sector facilities had access to a laboratory, 83% in the CY facilities, and 68% in the non-CY. Blood bank, again, public sector 4%, private sector 2%, private CY 2%, and non-CY 2%. Blood banking has been an issue particularly, but it's also because blood banks tend to be much more centralized, and then they have sort of connections with the blood banks where they access the blood from. Ultrasound, again, you can see that the proportion of facilities that had an ultrasound machine in their facilities are much higher in the private healthcare sector as opposed to public. Radiant warmers were more because I think there's been a lot of focus on neonatal care. But in general, if you were to look at the slide more in detail, you'd actually see that they were better equipped facilities in the private healthcare sector and in those participating in the program. Now, I think another element of quality when you run a demand-side financing program is also how you finance the program, because that is something that's going to actually determine quality. What is really the financial incentive that is in place? Because you need to really deter induced demand, because this is a private sector that's operating out of pocket with fairly slim regulation, I'd say. So how do you deter this demand for unnecessary cesarean sections? And so the way the program was designed, the financial incentives, they actually called together non-governmental organizations, professional organizations, the Federation of Obstetricians and Gynecologists of India. And then they had people from academia, etc., sit together and say, okay, how do we cost this now? How are we going to work with this? And in principle, it looks like this. So they said, if you have 100 deliveries, 85 are going to be normal vaginal deliveries with absolutely no issues. 8 will probably have some kind of complication which may require a blood transfusion, may require forceps, may require something extra. And 7 would be cesarean sections. So they costed what each of those would cost. And so you're paid per 100 deliveries 85X, 8Y, and 7Z. So you just get this. It doesn't matter how many vaginal deliveries you do, how many cesareans you do, how many complications you see. This is kind of fixed. This whole block package has gone up in steps roughly every 3 years because of either discontent or inflation or whatever you have. Now, cesarean section under the Chiranjeevi program. So the idea is actually to increase access to specialized emergency obstetric care. It's been on average 6% per year. 6% of vulnerable women have had a cesarean section under the CY program, which is very close to what they assumed in the costing. If you look there, they assumed 7 cesarean sections. But it's still an improvement on what previous national surveys in that state said, because in the lowest quintile, wealth quintile, actually had just 2% cesarean sections. So it's gone up to 6%. But then the question is, did everyone who really needed the cesarean get it or not get it? That's hard to say. So we don't really know. or is it that some are being converted into non-beneficiaries if they need special care? Say, no, you can't have it under the program, or we don't really know. It's really hard to look at this because it's so sensitive. Then the other thing which I think is important to maintaining quality is accountability, and sometimes this is a problem in public healthcare systems, accountability to the client or the user. Now the thing is, the private practitioner who sets down roots in a particular small town, etc., has a lot at stake. He's got a lot to lose. He has one death or he has one botch up, and that's the end of his reputation there. So reputation is very, very critical for these private obstetricians, and they will do anything to make sure that the patient walks out well because of that. It drives pressure for good outcomes, and also therefore there's also very close supervision of all the staff and what's happening at the facility. They never leave. They live close by often, and then the skilled birth attendant has 24/7 access to that gynecologist. There have been some suggestions and accusations of cherry picking cases, that if a case gets difficult then they refer it out and into the state sector. But there's also been accusations of it happening the other way, that the state refers difficult cases, or difficult cases who know they're being mismanaged in the state hospitals will then move into the private. So I think I would say probably crosses itself out, but it's an accusation nevertheless. Quality in the processes of care. Now this is particularly tricky because there are two aspects to this. There's the technical quality of care, so is the patient managed as per scientific protocols, and is she treated well, because she's a poor woman, she's vulnerable, she's tribal, etc., etc. Now this has been really difficult to assess in the context of the CY program because these are private facilities, and there is no law that requires them to let us in to see what they do, and it could also be threatening in a way. So while we've been able to do this in state facilities, when we were looking at the conditional cash transfer which is run through the state, it was very, very challenging to get a peep into what really goes on in these facilities. So it's hard to actually say what's really going on, and we don't really know. There are no standardized formats by which they report information that we could look through, etc., to know what's going on with that. So while quality of the processes of care is terribly, terribly important, there isn't any mechanism in place by which that is kind of checked or monitored, etc., which is a drawback. The last thing is the impact indicators of quality of care. Like I said, it's to look at maternal deaths, which is tricky because they're so few, and secondly, they're not disaggregated by the state at the moment into program deaths and non-program deaths. So we can't really say which of those deaths happen where. We just have a list of the maternal deaths. And then morbidity, again, is there are no standard reporting formats, and it's difficult to make comparisons because what one person calls hemorrhage, another person may not, etc. Then as an aside, before I conclude this lecture, is that because this has been a push with the private sector, because we've involved the private sector in delivering emergency obstetric care, there's been concern in some quarters of government about whether this has actually weakened the public sector in any way, whether it's influenced the public sector proportions in the state. So what we did is we actually took data from the state, which looked at institutional deliveries over the last 10 years from the Department of Health, and did piecewise regressions to look at changes in the public and private sector deliveries that were happening. And actually, the CY program did not actually change the proportion of public sector deliveries. It has stayed constant from before the CY and after the CY. If anything, there was a slight rise in trends in public sector deliveries, but it wasn't statistically significant. So the answer to that question is actually no. It did not really affect public sector proportions. And structural problems with the public sector will probably take time to resolve. It's going to be a long-term, you require a long-term solution. So the government has sort of presented the CY as a medium-term strategy to kind of provide care till we have a public sector that is able to, till there is a public sector that is able to actually take on this responsibility. So in conclusion, this is a large public-private partnership. There have been 1 million deliveries under this program. There's been no impact on public sector institutional delivery proportions because of the program. There are some inbuilt measures already to ensure quality of care, the level of EmOC functioning, the entry criteria, human resources, supplies, equipment. But it's been very difficult to assess processes and impact measures for the reasons that I just talked about. So I'd like to acknowledge all partners on the Maternal project, particularly the Indian Institute of Public Health in Gandhinagar, Gujarat, the Department of Health and Family Welfare of the Government of Gujarat who've helped with this assessment, and the EU FP7 program for funding the Maternal project that works with this. Thank you.